Thank you, Dr. V.Mohan. I must admit that it's a true center of learning, and I think in the last 2 days we are all mindful that people are tired, but the interest in these molecules, particularly the GLP-1 class of agents, has been completely revolutionary, I would say. And these are game-changing molecules. And today our focus in the next 3 talks is going to be semaglutide 2.4 milligram, which is just recently been available in India. And I'm going to talk on the stepping of the obesity medication pathway. These are my duality and conflicts. This is contracted by Novo Nordisk, and this is a talk which I have a duality and conflict, and these are my other disclosures as mandated. So clearly, when we look at high efficacy obesity management medications, semaglutide, injectable and oral, both are in that space, and the 2.4 milligram Wegovy, which is just launched, is very, very much there. But we all know that there are, is obesity only a result of voluntary excessive energy intake, decreased energy expenditure? Is it biological, because brain controls eating behavior and appetite? Is it genomic? We had a very nice talk on from Sarah on this. Around 40 to 70% of our weight is dependent on our genetic makeup. Is it linked to mind, psychological stress, psychological distress, which impacts appetite? We all are very mindful in our society, in our Southeast Asian geography. Social health and societal determinants and inequalities play a huge role. Medications also promote weight gain, including some medications linked to mental health and neurological space. And we also know the environmental disruptors, unhealthy eating patterns, sedentary lifestyle, and all this is contributing to a disease called obesity now. So we know that there are many factors and paths which lead to obesity, but we recognize one fact that it's not a cosmetic issue, it's a chronic disease. And I don't like the word obesity personally. I feel it's fat or adiposity, which is the correct term. And it's the abnormal or ectopic or excess adiposity which impairs health and happiness both. And it increases and propels long-term medical complications, more than 250 of them, and they clearly reduce lifespan. We also know this appetite control, and we know the role of brain regulating appetite, and we also know that we can eat for hunger, which is controlled by endocrine feedback, which is homeostatic. Hedonic word is very popular. Me and Professor Mohan having lunch together today, and we were all hedonic when we were having a little bit of fig ice cream. And it's eating for pleasure, which is controlled by the brain's reward system. And sometimes we just don't think, we just eat, it's reflex. So clearly we recognize the 3-layer appetite system, and the brain controls the eating behavior and appetite, and weight is determined and regulated by this entire pathway, and we have a new generation pharmacotherapy. So there's a constant tug and war between losing and maintaining weight loss and diet and exercise alone. Whether it's the calories, the activities, the metabolism, the hunger hormones, the fullness hormones, there's a constant yo-yo which we recognize worldwide, and it's a struggle. So lifestyle is very much there, but it's constantly a struggle which we all recognize. And despite therefore of best efforts, metabolic changes, when we lose weight, the body's metabolic adaptation is to promote regain. And now we are looking at a molecule which is just got in, and that's my mandate to talk to all of you all, is to educate you all on how semaglutide or Wegovy 2.4 milligram is here to stay. We had earlier, a couple of months back, a launch of tirzepatide in India, and we clearly recognize that semaglutide 2.4 milligram is a GLP-1 receptor agent which works on the key areas of the brain to control hunger and cravings. We know that this is a human GLP-1 analog. It is a 94% homology with the human GLP-1. Its half-life is around a week. It directly activates the hypothalamus and the hindbrain, and clearly we recognize those pathways, and clearly we recognize that it's involved in making you feel full and make you feel less hungry which is the homeostatic appetite regulation. And on the hedonic side, it is an anti-craving agent and modulates our food preferences. And therefore, food industry is also worried. So clearly we recognize that the semaglutide, 2.4 milligram, switches on the appetite by regulating fundamentally the satiety and make you feel less hungry, and switches off the crave and changes your food preferences. Novo did almost a plethora of trials, some of which I will allude to, with more than 33 million years of exposure to semaglutide. So it's an extremely evidence-based molecule from a pharmaceutical standpoint. In the phase 3 program, the trials involved more than 26,000 population and participants. Step 1 being for weight management, step 2 being for type 2 diabetes, step 3 being for weight management with intensive behavior therapy, step 4 being sustained weight management, step 5 being long-term weight management, step 6 being in East Asians, step 7 being in China, Brazil, Korea, Hong Kong, step 8 being obesity head-to-head with liraglutide once a day, step 9 being for osteoarthritis, 10 for pre-diabetes, 11 for Korea and Thailand, step teens for adolescents, and then we have the select, which Beverly will talk on, the obesity and cardiovascular outcomes, step preserved ejection fraction, step preserved ejection fraction with diabetes and type 2, essence for MASH, step up for weight management with 7.2, and step up type 2 diabetes with weight management with 7.2. So actually the next generation we beyond this also is in the pipeline. So clearly we recognize that. And when we look at Indian studies on semaglutide, we have more than 3,500 population which participated in these various clinical trial programs. We clearly recognize semaglutide 2.4 or Wegovy there were 117 patients from India in step 1, 164 for step 2, 492 for select, step preserved HF with diabetes 55, so totally 828 patients, essence 30, sustained 2, 4, 7, 8, 11, all put together a reasonable population of more than 1,000 plus patients, including flow and stride and focus to 18. And in the pioneer, which we had earlier, and we have access to oral semaglutide for almost now 3 years, clearly the SOUL program and pioneer program had more than 1,600 patients plus which were available. So let's look at step 1, which is clearly semaglutide 2.4 in patients with overweight and obesity. And clearly you can see a placebo-controlled trial with lifestyle intervention, and the primary endpoint is weight loss, and secondary confirmed endpoint is on cardiometabolic risk. And you could clearly see that this weight loss with semaglutide compared to lifestyle intervention alone was 2.4% reduction from week 0 to 68 and 16.9% reduction from week 0 to 68. So you could clearly see the curve and the graph moving very quick and fast as far as weight loss was concerned, 16.9% weight loss reduction. If you look at clinically meaningful weight loss, which means the population which lost more than 5% over 68 weeks as an adjunct to reduce energy diet and physical activity, 20% and more weight loss was seen in 1 out of 3 patients. So clearly you can see the graphic is very compelling, and the statistic is also very compelling when it comes to the outcomes. When it came to the secondary endpoints, confirmed and supportive, which include cardiovascular risk factors, clearly we can see here that waist circumference drops by around 15.2 centimeters, systolic blood pressure by 7.1 millimeter, and the overall score for physical function improves by 2.56. On the supportive secondary endpoints, though this is a non-diabetic population, 0.5% A1C drop, diastolic blood pressure drop, and a significant drop in the inflammatory parameter of CRP to 58%. When we move the gear on the maintenance program of step 4, you can clearly see that effect of maintaining semaglutide versus treatment withdrawal. And again, here very clearly you can see on the co-primary endpoints of change of body weight and on the secondary endpoints on waist circumference, systolic blood pressure, physical functioning score, you can clearly see in this population, again the maintenance dose of semaglutide was having a sustained weight loss over a period of time. And the population which continued from week 0 to 68 had more than 20% weight loss out of 1 in 3 and 18.2% reduction compared to a slope which went up after on the placebo side. When we look at 2-year long-term maintenance data, clearly again the data from step 5 comes here, and again you can see a 16.7% reduction and more than 20%, and the number of 20 is pretty compelling, and therefore you could clearly see that this weight loss is sustained. Also we have the SELECT trial, which I would not allude to, which demonstrated weight loss was achieved in Wegovy, which was sustained for 4 years after the treatment was continued. So when we look at combination of all the 3 programs, step 1, 4 and 5, and if you look at GI side effects, we all know that they are transient, they are self-limiting, they are mild to moderate, predominantly in the GI space, very rare fatal or serious adverse events, and discontinuation is also less. So finally, I summarize that semaglutide is here to stay in eligible patients for obesity in 2.4 milligrams. Clearly, it is suitable and approved in India by our Drug Control Journal of India for adult patients for BMI about 27 in presence of at least one weight-related comorbidity or independent of comorbidity for a BMI more than 30. What data shows us, including Indian data, are 3 simple points. A sustained 20% weight loss in 1 out of 3 patients at 68 weeks with at least a 15 to 17% weight loss. I'm not talking of fat loss. That will be much more, and we'll have real world experience in a year or 2 when we actually use it in our population. A sustained weight loss over 4 years with a safety profile which is consistent with the entire GLP-1 space, and clearly we see significant health gains in CV risk factors, physical functions versus lifestyle alone. So this agent is clearly here to stay, and I thank you very much for your patient attention, and I think we are looking forward to Beverly to give her talk, and I would request Dr. Mohan to introduce her. Thank you.